Hello everyone, myself is Dr. Tejas Patel, and in this session I am going to talk about how to detect adverse drug reactions. At the end of this session, you should be able to understand different criteria to suspect adverse drug reactions. This is the learning objective of this session. Now, it is not easy to determine whether a patient is experiencing an adverse effect from a drug. This is because many times patients who are experiencing an adverse effect rarely think the problem was caused by a drug that they are taking. Many times they think it is because of the manifestation of some disease or due to food that they are taking. So clinicians should always suspicious for adverse drug reactions in case of all untoward medical occurrences that may present during treatment. In short, all adverse drug events should be explored for adverse drug reactions, and clinicians should always explore the possibility of adverse drug reactions in case of exacerbation of patient's clinical condition or a emergence of new clinical problem while managing a patient, as ADRs many times act through same pathophysiological pathways as different diseases. For example, headache, dizziness, vertigo, or simple vomiting, diarrhea, cough could be because of adverse drug reaction or symptoms of a disease. So clinician should always explore the possibility of adverse drug reactions in case of all untoward occurrences, and adverse drug reaction should be a differential diagnosis. Now ADR is suspected based on time relationship, that means timing of the administration of the drug and development of adverse drug reactions. Then pharmacological property of the drug, then likelihood or exclusion of other causes that are the concomitant drugs and underlying disease. D-challenge, that means withdrawal of a drug, what happens after the withdrawal of a drug, whether reaction improves or not. Then re-challenge means re-administration of the suspected drug and what happens to adverse drug reaction after this. The first we will discuss about time relationship. So it is a temporal relationship between the administration of the suspected drug and onset of ADR. So there should be a reasonable time relationship. Now before that, one need to ensure that medicine ordered is the medicine received and actually taken by the patient at doses prescribed. One should explore the all detailed history about all medications taken by the patient, including over-the-counter medications. And then one need to think from the point of view of reasonable time relationship, and that is based on the pharmacokinetics and type of the reactions. From pharmacokinetic, half-life of a drug is an important factor. For example, diazepam is a one type of benzodiazepine. It's a hypnotic agent, so used for insomnia at night time. It can cause next day sedation and psychomotor impairment because of its longer half-life. Then many adverse drug reactions characteristic timings for its appearance. For example, anaphylaxis, type 1 hypersensitivity reaction, usually occurs within minutes after the administration of a drug. We will understand with one hypothetical case scenario. A 15-year-old female patient was a known case of bronchial asthma for last 1 year and rheumatic fever for last 3 months. She was on inhaled budesonide plus formoterol puff twice daily for asthma. She was also on benzathine penicillin monthly prophylaxis against rheumatic fever. Now on next scheduled visit, she took 1 budesonide plus salbutamol puff for asthma in the morning, and 2 hours later came to medicine OPD for her prophylactic dose of benzathine penicillin. Within minutes of receiving injection benzathine penicillin, she developed swollen face, difficulty in breathing and low blood pressure. So here the respiratory involvement, cutaneous reactions and cardiovascular symptoms in a short span of time within minutes after the administration of a benzathine penicillin indicates anaphylactic reactions. And that rules out the possibility of budesonide and salbutamol puff as a causative agent. Another example is of the Stevens-Johnson syndrome. Is a type 3 hypersensitivity reaction, usually affects the skin and mucous membranes, in which cell death causes epidermis to separate from dermis and widespread blisters happens. It usually occurs after 1 to 3 weeks of starting the offending drug. Now we'll understand with another case scenario. A 50-year-old male patient presented to emergency department with itching, skin lesions and unable to take oral fluid. On examination, he had tachycardia, blistered skin lesions and pronounced oral ulceration. He was diagnosed to have Stevens-Johnson syndrome. Now on detailed history, he was known case of diabetes on treatment with glimepiride and metformin for the last 2 years. He was also on carbamazepine for last 15 days due to diabetic neuropathy. So here the timing of last 15 days for carbamazepine as a causative agent of Stevens-Johnson syndrome, while glimepiride and metformin patient was receiving since last 2 years. So reasonable temporal relationship or reasonable time period of 15 days supports carbamazepine as a causative agents in this case. And second important criteria for the suspicion of drug is pharmacology property of the drug. Based on the pharmacological property, now we know there are two types of the reaction: type A augmented and type B bizarre. The type A reactions are predictable based on its pharmacological effects, while type B or bizarre type of the reactions cannot be predicted because they are based on the patient characteristics. So first we need to think about whether it is an augmented type of reaction or bizarre type of the reactions. So all allergic reactions are considered as a bizarre type of the reactions. So if it is an allergic reactions, that means it cannot be explained with the pharmacological property of the drugs. Now we'll understand again with the case scenario. A 5-year-old child brought by the parents to the general practitioner for the vomiting, diarrhea with mild dehydration since yesterday. He was prescribed tablet metoclopramide, tablet resicadotryl and plenty of ORS for 2 days. He was advised follow-up after 2 days. However, he brought to casualty within 2 hours of taking first dose of prescribed drugs for severe spasm of neck muscles and eyeballs rolling up. He was diagnosed to have extrapyramidal syndrome, that is acute muscle dystonia, and he was managed for the dystonia with the promethazine. So here in this case, patient develops the extrapyramidal syndrome. We know extrapyramidal syndrome develops because of the deficiency of the dopamine or dopamine receptor blockage into the corpus trium or basal ganglia. So if we explore the drugs, patient consumed 2 drugs, resicadotryl and metoclopramide, before the development of the reactions. So based on the timing, both drugs are there. Patient has consumed both the drugs. But if we explore the pharmacological property of the drugs, resicadotryl is an anti-secretory drugs which inhibits the enkephalinase enzyme, while metoclopramide is a dopamine receptor blockers. So that suggests metoclopramide as a causative agent in this case scenario, and which rules out the resicadotryl. So parents were advised not to give tablet metoclopramide to the child, and he was prescribed promethazine for next 2 days and advised to continue resicadotryl and ORS as per the schedule. Now we'll understand the different case scenario. An 18-year-old girl present to the emergency department with fever, unable to take oral food and widespread blisters. On examination, she was febrile, had blistered skin lesions, pronounced eye, oral and genital mucosal ulceration. She was diagnosed to have Stevens-Johnson syndrome and admitted in ICU. Now on detailed history, she was recently diagnosed with epilepsy and was receiving carbamazepine and phenytoin orally for last 15 days. So here the Stevens-Johnson syndrome is a allergic reaction, a bizarre type of the reactions. And time relationship suggests both carbamazepine and phenytoin were taken between the lag periods for the development of Stevens-Johnson syndrome. As it is a bizarre type of the reactions, we cannot differentiate whether it is due to carbamazepine or phenytoin. So both drugs are suspected, and the consultant stopped both phenytoin and carbamazepine, and she was managed for Stevens-Johnson syndrome. So in case of the augmented reactions, the reaction is predictable based on the pharmacological property, while in case of the bizarre or allergic type of the reactions, it cannot be predicted based on the pharmacological property of the drugs. Now third important factor is likelihood or exclusion of other causes. For that, one need to think from the point of view of other concomitant drugs and underlying disease for which patient is receiving medications. And one need to think medical plausibility based on the characteristic history, signs and symptoms, laboratory tests and pathological findings. So another case scenario, a 30-year-old male patient came to dermatology OPD with severe itching and generalized maculopapular rash all over the body. Now on detailed history, he had consulted a general practitioner for upper respiratory tract infection and was receiving azithromycin, paracetamol, multivitamin since yesterday. He also had a history of severe itching due to some painkiller drug 6 months back. So we now know itching and generalized maculopapular rash are allergic reactions, example of bizarre type of the reactions. So they cannot be explained with the pharmacological properties of azithromycin, paracetamol and multivitamin. However, patient has a history of severe itching due to some painkiller drug. So that's the paracetamol as a causative agent in this scenario, and which rules out the azithromycin and multivitamin as a possible agents. If such history is not available, we are supposed to suspect all drugs here: azithromycin, paracetamol and multivitamin. So now dermatologist suspected tablet paracetamol to cause reaction and stopped it. He treated the patient with antihistamines and steroids. He continued other drugs as per the schedule. Another case scenario, a 30-year-old woman presented to medicine OPD with complaint of vomiting, abdominal pain and jaundice for last 3 days. Her SGPT was 500 international unit and my viral markers for hepatitis were negative. On detailed drug history, she was on category 1 DOTS containing isoniazid, rifampicin, pyrazinamide, ethambutol and vitamin B complex for pulmonary tuberculosis for last 1 month. Physician diagnosed the anti-tubercular drug-induced hepatitis and refers patient to TB and chest department for further management. So here in this case scenario, diagnosis of drug-induced hepatitis was made based on ruling out of viral hepatitis based on its markers and history of the anti-tubercular drugs in a last 1 month. So again, it's a reasonable time relationship, 1 month, and physician referred it to the TB and chest department. Now if we explore the drugs received by the patients, patient was receiving 3 hepatotoxic drugs: isoniazid, rifampicin and pyrazinamide. So consultant in TB and chest department suspected isoniazid, rifampicin and pyrazinamide as a cause and stopped them. Fourth important factor is a de-challenge. De-challenge means stopping of the drug or reduction into the dose of the suspected drugs after the occurrence of adverse event. So this is the usual clinical decision after the occurrence of the adverse drug reactions. If they causes distressing to the patients, they are harming the patients, they are not tolerable to the patients, and we usually prescribe alternative drugs in this case scenario. Now what happens to the reactions after the D challenge is an important factor in deciding the association between the suspected drugs and adverse drug reactions. So we look for whether the reaction subsides after the withdrawal of the drug or does not subside. So if the reaction subsides after the withdrawal of the drug, that means suspected drugs could have caused the reaction. It indicates positive D challenge. If reaction does not subside, suspected drug is unlikely to cause the reaction. It is considered as a negative D challenge. Again, if you take our previous example of paracetamol induced severe itching and generalized maculopapular rash. So after stopping of the paracetamol, we are interested in knowing whether patient improved from the reaction or does not improve from the reaction. So at the end, patient was recovered completely after 1 week. So it suggests paracetamol as a causative agent for the generalized maculopapular rash, and it rules out the azithromycin and multivitamin for its causative agent. If patient does not improve, then there could be a possibility that either other drugs or some other problem could have caused this reaction. Another case scenario, we previously discussed anti-tubercular drug induced hepatitis, and we suspected isoniazid, rifampicin and pyrazinamide based on its known action and stopped them. So after 1 week, patient improves, SCPT comes down. So it supports our suspicions. The suspected agent could be one of the isoniazid, rifampicin and pyrazinamide. It helps us to rule out ethambutol and vitamin B complex as a causative agent for the drug-induced hepatitis. But what is the limitation of D challenge in this case scenario? Because in this case scenario, we have stopped the multiple drugs, so we could not pinpoint whether it is improvement because of the withdrawal of isoniazid or rifampicin or pyrazinamide. So positive D challenge cannot pinpoint a suspected drug if multiple drugs are stopped. And D challenge is also not applicable in case of single dose treatment and delayed reactions. Now the re-challenge. It refers to the restarting of the same medication after stopping it. It could be complete or partial. So re-challenge may start with same dose or with the low doses. And after reintroduction, we are interested in knowing what happens to adverse drug reactions, whether it reappears or not. If the reaction reappears after the reintroduction of the drugs, it confirms the association between drugs and reaction because it has a now repeat value, and it is considered as a positive re-challenge. And if reaction does not reappear after the reintroduction of suspected drug, it rules out the association between drugs and reaction. So it is considered as a negative re-challenge. Again, if you see our previous example, anti-tubercular drug induced hepatitis, we stopped isoniazid, rifampicin and pyrazinamide. Patient improved after 1 week. So now the consultant planned the gradual reintroduction of suspected drugs. First, he reintroduced rifampicin and hepatitis did not occur on follow-up at the end of 1 week. So the reaction here is did not reappear, and that rules out the rifampicin as a causative agent for hepatitis. Now consultant continued rifampicin and reintroduced isoniazid. Hepatitis did not occur on follow-up at the end of 2nd week, and he continued rifampicin and isoniazid. That means re-challenge is also negative for isoniazid, and isoniazid in this case scenario rules out as a causative agent for hepatitis. Lastly, he reintroduced pyrazinamide, and hepatitis occurred on follow-up at the end of 3rd week. So reappearance of hepatitis after the introduction of pyrazinamide in this case scenario confirms the association of pyrazinamide with hepatitis. Now consultant reconstitute the antitubercular regime with the omission of pyrazinamide for the management. But it is usual clinical scenario. Now asking one question, should we do re-challenge in all cases to confirm the association? So re-challenge is not possible in all cases due to ethical reason, because reappearance of the lesion is causing distress to the patient, it may harm the patients. So it is not permissible in all cases. It should not be attempted in life-threatening reaction because subsequent reaction could be fatal also. Re-challenge or reintroduction of the suspected drug should only be attempted in the best interest of the patient when effective alternative measures are not available. We have performed the reintroduction of suspected drug in case of antitubercular drugs because the first line antitubercular drugs are most efficacious in case of pulmonary tuberculosis, and patient cannot be deprived of all the three antitubercular drugs, and other alternative, that is second line antitubercular drugs, are less effective and more toxic as compared to first line antitubercular drugs. So we plan gradual reintroduction of the drugs to identify one culprit. We have previously discussed a case of Stevens-Johnson syndrome because of the carbamazepine and phenytoin, and we stopped both phenytoin and carbamazepine. Now, should we do re-challenge with phenytoin and carbamazepine to identify whether the reaction is caused by carbamazepine or phenytoin? So, that depends on the severity of the lesion. Here, the Stevens-Johnson syndrome is a serious cutaneous reaction. It may cause life-threatening reactions, and safer anti-epileptic drugs are available, so better alternatives are available for the patients. So in this case scenario, the answer is no, and some alternative anti-epileptic drugs should be prescribed, and patients should be advised not to have phenytoin and carbamazepine in future. So on discharge, patient was prescribed sodium valproate 300 mg BD. Another case scenario, we previously discussed paracetamol induced itching and generalized maculopapular rash. So should we give paracetamol to the patient into the future? Again, the answer is not with paracetamol. However, for the analgesics and antipyretic purposes, other NSAIDs can be prescribed to the patient, but that too under observation, because NSAIDs shows partial cross reactivity. And remember, whenever re-challenge is performed, it must be under observation, because subsequent reaction could be more fatal and more dangerous or more in severity. A re-challenge is not applicable in case of single dose treatment, delayed reactions, and whenever drug was not discontinued. So these are the important points about how to suspect adverse drug reactions. So all adverse drug reactions are suspected based on the temporal relationship, pharmacological properties of the drugs, and exclusion of the concomitant drugs and underlying disease. And whenever possible, we perform de-challenge and re-challenge only in some cases, in the best interest of the patients. Now at last, we'll discuss about some of the factors which affects the development of adverse drug reactions. First important factor is the age of the patients, particularly elderly and pediatric patients are susceptible to adverse drug reactions due to their altered pharmacokinetic and dynamics, especially elderly patients because of the progressive decline in renal functions. Second factor is prior history of adverse drug reaction. That is important, particularly in case of allergic reactions, and one should also think from the point of view of cross reaction between pharmacologically similar group of drugs. That means allergic reaction to one penicillin group of drugs, that means chances of allergic reaction to other penicillin group of drugs. Third important factor is dose and duration of exposure. higher doses and longer duration of exposure to drugs increases chances of occurrence of adverse drug reactions. Then altered and renal functions decreases the clearance of drugs and increases the chances of adverse drug reactions. And lastly, polypharmacy is also important factor which increases the possibility of drug-drug interactions and adverse drug reactions. So this is a graph which shows ADR frequency by drug use. On x-axis number of medications are there, and on y-axis frequency of occurrence of adverse drug reactions. So graph suggests more medications in a regime, the greater is the likelihood of a adverse drug reactions. So we should be vigilant for adverse drug reactions in case of polypharmacy. Thank you very much.